Hi everybody, welcome to our module on colon cancer. Before we talk about colon cancer, let's talk about colon polyps. So a polyp in the colon is a raised outgrowth of tissue that sticks out into the lumen of the colon. And some polyps are precancerous, and if they can be identified before they develop into cancer, removal can prevent colon cancer. And this is a picture of what a colon polyp can look like on a colonoscopy. And part of the reason that adults over 40 or 50 years old are recommended to have regular colonoscopies is so that any polyps can be identified early and removed before they develop into colon cancer. The most common type of polyp is called a hyperplastic polyp, and luckily it is benign. And this is useful to know when you get a call from your uncle or your grandmother saying that they had a polyp discovered at colonoscopy. You can tell them that most likely it's a hyperplastic polyp and it's benign. They're common in the rectosigmoid junction and they have normal cellular structure. There's no dysplasia of the tissue found in polyps. They classically have a sawtooth or serrated pattern. I'll show you a picture of that in a minute. And there's usually no special screening required after biopsy. So the way this usually happens is a patient has a colonoscopy, a polyp is identified and removed, and the analysis from the pathologist comes back that it is a hyperplastic polyp, and then the gastroenterologist can let the patient know that they don't need any special screening. It was a benign polyp. This is the sawtooth or serrated pattern of a hyperplastic polyp. There are these finger-like projections sticking out from the polyp. They're made up of normal colonic mucosal cells. There's no dysplasia occurring, and this is what you typically see in a biopsy of a hyperplastic polyp. In contrast to hyperplastic polyps, there is another type of polyp called an adenomatous polyp that can be found in the colon, and these are dysplastic and they do have malignant potential to develop into colon cancer. And there are several different ways by which adenomatous polyps can be subclassified. First is by shape. They can have a sessile or a pedunculated shape. We'll talk about that in a minute. And the second way is by histology. Some have what's called tubular histology and some have villus histology. To understand the difference between a sessile and a pedunculated polyp, imagine that we have the wall of the colon here. A sessile polyp has a broad base with extensions out into the lumen of the colon. A pedunculated polyp, on the other hand, has a stalk attached to a little ball at the end, and the ball contains the dysplastic polyp tissue. The more important distinction has to do with the appearance of the polyp under the microscope. There are two types of histology seen in colon polyps. The first is called tubular and the second is called villus. Tubular polyps are the more common subtype of adenomatous polyps. 80% or more are tubular, and tubular polyps have adenomatous epithelium forming tubules. I'll show you a picture of that in a minute. The less common histologic type of an adenomatous polyp in the colon is called the villus type. These are often sessile and they have long projections extending from the surface, and there's a very high risk of this type of polyp developing into colon cancer. This is a picture of a tubular polyp here, and you can see that the polyp has formed these tubules, and that's how it gets its name. And this is an example of a villus polyp. You can see that it contains these finger-like projections, or villi, which is how it gets its name of villus polyp. And the surface of each of these finger-like projections is dysplastic cells that carry a high risk of converting into colon cancer. Most polyps do not cause symptoms. They are almost always asymptomatic, and this is the basis for performing screening colonoscopy to try and detect polyps and remove them before they progress to colon cancer. Some larger polyps can bleed. It's usually a very small amount of blood that is not visible in the stool. It's called occult bleeding, and this is the basis for some colon cancer screening programs where the stool is tested for the presence of occult blood, and if occult blood is found, then the patient is referred for a colonoscopy. Some large villus adenomas can cause a diarrheal illness. As I told you before, many villus adenomas are sessile, and some of them have a very large broad base, sometimes as big as 3 to 4 centimeters in size. This can lead to excessive mucus production and cause a secretory diarrhea. This usually happens when the villus adenoma is located near the junction of the sigmoid colon with the rectum. It causes a watery diarrhea, and sometimes the watery diarrhea can progress to cause hypokalemia. This is a rare syndrome, but if you're interested in learning more about it, I've listed a nice case report at the bottom of the screen of a patient who had severe electrolyte abnormalities related to a diarrheal illness caused by a villus adenoma. Any adenomatous polyp discovered at colonoscopy carries a risk of development into colon cancer, but there are certain high-risk features of polyps that you need to know, and these are important for taking care of patients because if any of these are discovered at screening colonoscopy, it means the patient is at greater risk and needs to be screened more regularly. So first of all, there are some high-risk features of an individual polyp that mean the polyp is likely to develop into cancer. One of these is the presence of villus histology. I mentioned this before, but villus histology polyps are more likely to turn into cancer than tubular polyps. Many people remember that villus is the villain. Another feature of an individual polyp that indicates a higher risk of developing into colon cancer is the grade of dysplasia. This is determined by a pathologist. He or she examines tissue from the polyp under the microscope and assigns a grade of dysplasia based on how much dysplasia is seen, and polyps that have high grade dysplasia are at increased risk of developing into colon cancer. There are also some polyp features that mean the patient is more likely to develop polyps quickly in the future. A metachronous adenoma is a new lesion that occurs 6 months after a prior, and patients who have a polyp that is greater than 1 centimeter in diameter or who have multiple polyps are at increased risk for developing so-called metachronous adenomas, meaning new adenomas in a short period of time. So what all this means on this slide is that patients who have any of these features seen on the slide need more frequent colonoscopies because they are at greater risk of developing colon cancer. Now we've talked about hyperplastic polyps, which are the most common type of colon polyp, and we've also talked about adenomatous polyps, which are the worrisome type of colon polyp because they can develop into colon cancer. Now I'm going to talk about some other less common types of colon polyps, and I'll start by discussing juvenile polyps, which get their name because they occur in children. These are benign tumors. They are hamartomas that occur in children. And you may know that a hamartoma is a disorganized mass of normal tissue elements, so there's no dysplasia occurring. They usually develop in the rectum and they are usually pedunculated. They can cause painless rectal bleeding. They often auto-amputate, which means they just fall off and begin to bleed, and this can present as bleeding in a child or less commonly in iron deficiency anemia. There is a rare syndrome called the juvenile polyposis syndrome where children develop more than 10 of these polyps. Usually it is an isolated solitary polyp, but a child with more than 10 may have the juvenile polyposis syndrome. And what's important to know about this syndrome is that although hamartomas are usually considered benign, children with the juvenile polyposis syndrome have an increased risk of cancer, and there's surveillance colonoscopy that's performed in order to detect cancer at early stages. There's a rare syndrome called the Peutz-Jeghers syndrome, which is an autosomal dominant disorder where children develop multiple hamartomas throughout their GI tract. These are hamartomas just like the juvenile polyps we talked about in the last slide, but in this disorder they're often called Peutz-Jeghers polyps. Another feature of this syndrome is that there are pigmented spots on the lips and buccal mucosa of children with Peutz-Jeghers syndrome. In fact, that's often how it presents. The child is brought to the physician because of spots around the lips. This is a drawing of a child with the Peutz-Jeghers syndrome, and you can see the spots around the lips that are characteristic of the disorder. And because there are so many hamartomas throughout the GI tract, there is an increased risk of gastric, small intestinal, and colon cancer in people with the Peutz-Jeghers syndrome. Now I'm going to talk about the genetics of colon cancer, and there is a lot of basic science literature regarding the underlying genetic problems in colon cancer, and it can be overwhelming when you're a medical student. But basically, there are 3 things that you need to know about the genetics of colon cancer as a medical student, especially preparing for step 1. The first thing you need to know is that there are 2 fairly well-defined genetic pathways that lead to colon cancer. The first one is called the chromosomal instability pathway, and the second one is called the microsatellite instability pathway. And we'll talk about both of these in the next few slides. The second thing you need to know is that cyclooxygenase 2 expression is increased in colon cancer. This is the basis for using aspirin to prevent colon cancer. And then finally, you need to know that there is a gene called the DCC gene, which is mutated in advanced colorectal cancers. So in the next few slides, I'm going to go over these 3 points here, which are the highest yield things to understand about the genetics of colon cancer. The chromosomal instability pathway is also called the adenoma-carcinoma sequence, and it gets its name because it is a sequence of genetic events that occur in colon cancer as adenomas progress to develop into carcinoma. It's a series of genetic events that leads to colon cancer over many years. The progression from an adenoma to a carcinoma, the accumulation of all these genetic events probably takes 10 to 40 years. And it's a series of what are known as somatic mutations or spontaneous mutations that occur as we age. And this pathway of development of colon cancer is much more common in left-sided tumors. So if you look at this drawing on the bottom left side of the screen here, the left-sided colon is the colon over here. It includes the descending colon and the rectosigmoid. And the tumors that form over here most commonly form via a series of genetic events called the chromosomal instability pathway. The first step in the chromosomal instability pathway is a mutation of the APC gene. APC stands for adenomatous polyposis coli. It's a gene that encodes for a protein, and it functions as a tumor suppressor. What APC does is it prevents the accumulation of a substance called beta-catenin, which activates oncogenes. So normally when APC is functioning, it will suppress beta-catenin, and therefore oncogenes are not activated. However, if you lose the function of APC, this leads to an accumulation of beta-catenin, and this leads to oncogene activation. And when this happens, there's an increased risk for polyps, and this is the first step in the chromosomal instability pathway of colon cancer development. And I've shown this at the bottom of the screen. You begin with a normal colon and then you acquire an APC gene mutation, and now you have a colon which is at risk for the development of colon cancer. So to understand this, imagine that we have a normal portion of the mucosa of the colon. Remember that those epithelial cells are constantly sloughing off and being regenerated. Now imagine that some of those cells acquire an APC mutation. That cell will then begin copying itself and we'll get a collection of cells here that all have the APC mutation. This portion of the epithelium of the colon has now taken the first step towards development of colon cancer. The next step is a mutation of a gene called KRAS, which is a proto-oncogene. When there's a mutation in this gene, there is aberrant cell signaling, and this leads to adenoma polyp formation. So we talked before about adenomatous polyps, and the way they form via the chromosomal instability pathway is by first having an APC gene mutation acquired and then having a KRAS mutation. This converts a colon which is at risk into a colon with the presence of polyps. So if we go back to our normal colonic mucosa, we talked before about how a series of cells might acquire an APC mutation. If those cells then additionally acquire a KRAS mutation, they will begin to develop into a polyp extending out from the surface of the colonic mucosa. The final step in the chromosomal instability pathway involves the p53 gene. p53 is a tumor suppressor gene which plays a role in many different cancers, including colon cancer. Once p53 acquires a mutation, there can be tumor cell growth, and I've shown this at the bottom of the screen. So we begin with normal colon, we move through the APC gene mutation to an at-risk colon, we then acquire a KRAS mutation and we can develop polyps, and then finally there's a p53 mutation which leads to the development of colon cancer. And many colon cancers, especially on the left side of the colon, evolve by working their way through this genetic sequence, and it's called the chromosomal instability pathway. It's also called the adenoma carcinoma sequence. Once you understand that sequence of genetic events, it's very easy to understand a rare disorder called familial adenomatous polyposis, or FAP. This is an autosomal dominant disorder where patients are born with a germline mutation of the APC gene on chromosome 5. It's as if you are born with your entire colon already having an APC gene mutation, already having taken that first step towards colon cancer. This always, 100% of the time, progresses to colon cancer. The treatment is to remove the colon via colectomy. Shown on the screen is a colonoscopy image of a patient with familial adenomatous polyposis, and you can see numerous polyps throughout the colon, and that is typical of this disorder. There are a number of FAP variants. These are syndromes that all involve an APC gene mutation. They have polyposis of the colon plus extraintestinal signs and symptoms. And there are two FAP variants you should know as a medical student. First one is Gardner's syndrome. The second one is Turcotte syndrome. Gardner's syndrome is polyposis of the colon plus multiple extracolonic manifestations. And you can basically remember Gardner's syndrome by just remembering that it creates bumps all over the body. So in the bones, there are benign bone growths called osteomas, especially at the mandible. This will present as a bump on the jaw. There are bumps in the skin, which are skin cysts. They can be epidermal cysts or fibromas or lipomas. And then there are bumps in the connective tissue. These are connective tissue growths like desmoid tumors and fibromatosis. But all these things will present as bumps in the bones or the skin or the connective tissue. And then the final feature of Gardner's syndrome is something called hypertrophy of the retinal pigment. Congenital hypertrophy of the retinal pigment epithelium, or CHRPE, is when children are born with a flat dark spot on the retina. This can be seen on slit lamp exam. This is an example of it shown on the screen. You can see that there is a dark spot in the back of the eye. This is usually a benign finding with no symptoms. However, when it is identified, you need to consider that the child may have Gardner's syndrome, because when this finding is associated with polyposis, that is what you see in Gardner's syndrome. Turcotte syndrome is the other FAP variant. This is polyposis of the colon plus brain tumors, mostly medulloblastomas and gliomas. I talk about medulloblastomas and gliomas in the neurology modules, but I've shown you a picture of the Homer-Wright rosettes, which are classic for medulloblastoma, on the screen here to remind you of this association with polyposis seen in Turcotte syndrome. So as I told you before, there are two genetic pathways you should know that can lead to the development of colon cancer. We just talked about the adenoma carcinoma sequence, or the chromosomal instability pathway. Now I'm going to talk about the other pathway that leads to colon cancer. That's called the microsatellite instability pathway. This is a less common mechanism of colon cancer development. It is not as common as the adenoma carcinoma sequence. And this is more common in right-sided or proximal tumors. If we look at this picture at the bottom of the screen here, this is the right side of the colon. It includes the ascending colon on the right side of the body. And the microsatellite instability pathway can lead to colon cancers on this portion of the colon. And these can arise de novo without a polyp, so there's not necessarily a sequence that moves through an adenoma and then to colon cancer. Sometimes the colon cancer cells begin to develop spontaneously via the microsatellite instability pathway. So to understand this pathway, first let's define some terms. So let's talk about what a microsatellite is. Microsatellites are short segments of DNA, usually non-coding DNA, and they carry repeated sequences such as CA, 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 as I've shown in this example here. And they have a different density from other DNA, so they separate from other genetic material in testing. That's why they're called satellites, because they are separate from the bulk of our genetic material. A stable microsatellite means that successive cellular divisions lead to the same length of microsatellites. And in fact, each of us has a unique stable length of microsatellites. It's different from one person to the other, but it's same for each individual within our cells within successive cellular divisions. A DNA mismatch occurs when bases are mispaired. So as you know, bases should be paired in DNA. A goes with T and G goes with C. If the wrong base or nucleotide is inserted into DNA, that can lead to a mismatch. Now luckily, we have mismatch repair enzymes that resolve base errors. But if you have a gene mutation in a gene that codes for a mismatch repair enzyme, then that mismatch repair enzyme can become dysfunctional, and this can lead to an accumulation of errors. This can occur in the microsatellites of cancer cells, and that's one pathway by which colon cancer develops. This is called the microsatellite instability pathway. You can detect this on PCR testing, and what you will find is different lengths of the microsatellites in tumor cells versus the other cells in the body. In other words, the microsatellites are no longer stable from one cell to another. And this indicates an error in the mismatch repair enzymes, and that is one pathway by which colon cancer can occur. If you understand that sequence, it's very easy to understand the disorder HNPCC, which is hereditary non-polyposis colorectal cancer. It's also sometimes called Lynch syndrome. This is an inherited mutation of DNA mismatch repair enzymes, and it leads to colon cancer via the microsatellite instability pathway. There's about an 80% lifetime risk of developing colon cancer in people born with HNPCC. And as I told you before, these colon cancers will arise without a pre-existing adenoma, because the microsatellite instability pathway does not progress from an adenoma to a carcinoma. These are usually right-sided tumors. As I told you before, the microsatellite instability pathway is usually involved in right-sided tumors. And people with HNPCC are also at risk of other tumors. Importantly, they can get endometrial cancer among women. This is the most common non-colon malignancy in people with HNPCC. And they can also get other cancers like of the ovary, stomach, or other organs. And the classic case is a patient who has a right-sided colon cancer and has multiple first-degree family members who also have cancer. That person may have HNPCC, and they may have a mutation of DNA mismatch repair enzymes leading to cancer via the microsatellite instability pathway. Now that we've talked about the two genetic pathways that can lead to colon cancer, let's talk about another topic that falls under the genetics of colon cancer, and that is the overexpression of the enzyme cyclooxygenase 2. So recall that cyclooxygenase 2 is necessary for the production of eicosanoids. Eicosanoids are leukotrienes and prostaglandins and thromboxanes. They are very important cell signaling molecules, and cyclooxygenase is an enzyme necessary for synthesis of prostaglandins and thromboxanes from arachidonic acid. Increased expression of cyclooxygenase 2 is well described in colon cancer cells. It's more common in left-sided cancers, but it's also been described in right-sided cancers. And this is the rationale for aspirin therapy to prevent the development of colon cancer. Aspirin inhibits cyclooxygenase, and there are some data suggesting that aspirin reduces the risk of colorectal cancer by 20 to 40%. Unfortunately, there's a price that patients pay if they take aspirin every day. There's an increased risk of bleeding and ulcers, and there are no clinical trials showing that there's a reduced rate of mortality among patients who take aspirin every day to prevent colon cancer. Nevertheless, there are some groups that advise aspirin therapy to prevent colon cancer, and the basis for this recommendation is the understanding that cyclooxygenase 2 expression is increased in colon cancer cells. The final topic under the heading of genetics of colorectal cancer is the DCC gene. DCC stands for deleted in colorectal cancer gene. It's a tumor suppressor gene found on chromosome 18, and it is frequently mutated in advanced or aggressive colorectal cancers. Some people have advocated using it as a prognostic marker. Patients who have tumors with DCC gene mutations have lower survival. Now let's talk about colon cancer as a clinical disorder. Colon cancer is the third most common cancer and the third most deadly cancer, and it's more common after 50 years of age, and this is when we generally start screening people for colon cancer. It can occur anywhere in the colon, but different sites have different symptoms. We'll talk about that in a minute. And in general, the treatment is surgical removal of the tumor plus or minus chemotherapy, depending upon how extensive the cancer is. Colon cancers on the right side of the colon occur in the proximal or ascending colon, and these cancers tend to bleed slowly and present as iron deficiency anemia, and they also present as weight loss. And the reason they present this way is because they are what's known as exophytic tumors. And what an exophytic tumor does is it grows out from the lining of the colon. So if this is the lumen of the colon, an exophytic tumor will grow outward like this. Because it grows this way, it generally does not obstruct the movement of stool, and therefore the symptoms develop from slow bleeding and iron deficiency anemia and weight loss. And as we discussed before, right-sided tumors are associated with the microsatellite instability pathway of colon cancer development. Left-sided tumors, on the other hand, occur in the distal or descending colon, and they tend to present with left lower quadrant pain because they are often found in the left lower quadrant. They often present as blood-streaked stool. The cancer is near where stool exits the colon, and therefore streaks of blood are sometimes seen. And in contrast to right-sided colon cancers, left-sided colon cancers tend to develop as circumferential lesions. So if we're looking at the lumen of the colon here, they often grow outward and narrow the lumen of the colon. For this reason, they classically present as a change in stool caliber where the patient notices pencil-thin stools. And as we talked about before, left-sided colon cancers are the cancers that typically develop via the adenoma-carcinoma sequence. There will first be an adenomatous polyp, which will then develop into a carcinoma. The most common site of metastasis of colon cancer is to the liver. It will present with multiple spots of tumor on the liver, as is shown in this CAT scan on the screen. And we've touched on this before, but there are basically two methods of colon cancer screening. The first one is colonoscopy. It's usually recommended at age 50 and then every 10 years. Polyps, when they're identified, are removed and examined by a pathologist. And if you identify high-risk polyps, those patients will have increased frequency of screening. So instead of every 10 years, they may need a colonoscopy every 3 years or 5 years. The other option for colon cancer screening, which is less effective, is fecal occult blood testing. This is performed by a physician who does a digital rectal exam and then puts a bit of the stool on detection paper like I've shown at the bottom right side of the screen here. You can then drop a solution onto it and the color will change to blue if there is occult blood present in the stool sample. And if the fecal occult blood testing is positive for occult blood, then colonoscopy is recommended. Strep bovis is a colonic bacteria that is strongly associated with colon cancer. It's a normal colonic bacteria. It is a gram-positive cocci. It's gamma hemolytic. I talk about patterns of hemolysis in the ID modules. It is also a Lancefield group D bacteria, and very rarely it leads to bacteremia and endocarditis. And when it does cause bacteremia or endocarditis, it is strongly associated with the presence of colon cancer. So the classic board question is a patient who has a strep bovis endocarditis identified, and the question asks what test to do next, and the answer is colonoscopy because patients who have strep bovis endocarditis often have a colon cancer. The last topic I'll mention is the tumor marker CEA. CEA is the carcinoembryonic antigen. It is a tumor marker whose level is elevated in the serum in patients with colon cancer and also some other tumors, especially the pancreas. It has poor sensitivity and specificity for screening, so you can't check a CEA level to make a diagnosis of colon cancer. However, it is useful in patients who have established disease. The CEA level correlates with the disease burden. An elevated level should return to baseline after surgery or chemotherapy, so you can monitor the CEA level over time, and if it starts to rise, that suggests the patient may be having a relapse of their cancer. And that concludes our module on colon cancer.